Welcome to the deep dive. Today we're tackling a really unique neurological puzzle, Epilepsia Partialis Continua, or EPC.
hmm
Imagine a seizure that just keeps going, focused on one part of your body, all while you remain fully aware.
It's quite something.
Yeah. So we've gathered a stack of medical journal articles, some detailed case studies, and comprehensive reviews to really unpack what EPC is, what's behind it, and how experts understand it.
Think of this as your guide, really.
Exactly. A shortcut to getting a deep understanding of this pretty rare condition.
And our goal, in this deep dive is to give you a clear lens to view EPC through. It's a condition that touches on so many areas of neurology.
Right.
But we'll pull out the key insights, what defines it, the incredibly diverse triggers, and the strategies for diagnosis and treatment.
Basically getting to the core of this intriguing disorder.
That's the plan.
Okay, let's dive right in then. Across all our sources, the description that keeps coming up for EPC is these continuous involuntary muscle contractions.
Right, involuntary.
Confined to just one specific area of the body. We're talking about twitches, often sort of rhythmic.
Rhythmic twitching.
And they stubbornly persist for at least an hour minimum, sometimes much longer days, weeks.
Or even years in some cases. It's quite remarkable.
And what's really striking, as you said, is that throughout this, the person typically stays fully conscious.
Yes, that retained awareness is key.
Yeah.
It's a huge contrast to more common types of epilepsy where consciousness is usually impaired or lost.
It's fascinating. And looking back, the history is interesting, too.
Oh, absolutely. What's fascinating is that the first real detailed accounts came from Kojennikov, way back in the late 19th century.
Okay.
He observed patients with these relentless jerking movements in just one body part, movements that just didn't respond to the treatments they had then.
Wow. What did he think was causing it?
His initial theory was some kind of localized inflammation of the brain's outer layer, the cortex. Focal cortical encephalitis, he called it.
And the definition evolved.
It did. Much later, in 1977, Thomas and colleagues kind of refined it. They emphasized that key 1 hour minimum duration for the continuous activity.
1 hour. Okay.
And that the twitches should recur pretty rapidly, no more than about 10 seconds apart.
So it's very much a localized event, then. The sources really stress that.
Absolutely localized. Usually sticks to one limb, an arm or a leg is common. But it can also involve the face, the tongue, or other very specific muscle groups.
And the intensity varies.
Quite a bit, yeah. It could be anything from just a subtle flicker that maybe only the patient notices,
Right.
to movements that are really quite strong enough to seriously interfere with daily life. Things like writing or eating or using that limb.
That must be incredibly disruptive.
It really can be. And, to help make sense of this variability, Bancott and his team proposed a classification system back in '82.
Okay, how does that work?
They basically divided EPC into two main types. Type 1 is often called the classic form.
Classic EPC.
Right. It's typically linked to a pre-existing stable brain lesion, something that's already there and not changing much.
Like scarring from an old injury?
Exactly, or maybe a stroke. Often there's a history of other focal motor seizures before the EPC starts.
Yeah.
And the EEG, the brainwave test, usually shows localized abnormalities right near the lesion.
And the course.
Importantly, type 1 tends to be non-progressive. It doesn't usually get worse over time, and because there's often a clear target, surgery can sometimes be an option.
Who tends to get this type?
We often see this in older individuals, maybe someone who's had a stroke or encephalitis or even something like tuberculous meningitis in the past.
And the outlook.
Generally, the prognosis regarding cognitive function and how well treatment works tends to be a bit more favorable with type 1.
Okay, that's type 1. Then there's type 2. You mentioned it sounds quite different.
Very different, yes. Type 2 is often linked with Rasmussen.
Rasmussen encephalitis.
Precisely. Type 2 typically starts earlier in life, often in childhood. And the seizures are usually frequent right from the get-go.
More intense from the start.
Often, yes. And the EEG patterns look different too, more widespread, often with these characteristic slow spikes.
And the course is progressive.
Unfortunately, yes. This type tends to get worse over time and is frequently accompanied by neuropsychological symptoms, effects on thinking, learning, behavior.
That sounds much tougher.
It is. Brain imaging often shows more diffuse involvement, not just one neat lesion. And the muscle twitches, the myoclonus, might have a very short delay after the brainwave discharge.
So strongly associated with Rasmussen's.
Very much so. And because of that progressive nature and the underlying inflammation, the prognosis for type 2 is generally less optimistic.
It definitely sounds like EPC isn't just one single thing. The sources also really highlight quite a bit of variability in how it actually shows up.
That's a really critical point. EPC isn't monolithic at all. It can present as just a single, isolated episode. Someone has it for a while, and then it stops. Or it can become a recurring problem, coming back in episodes.
Right.
For some people, it settles into a chronic condition. That might be progressive, getting worse.
Like in type 2.
Exactly. Or it could be chronic but non-progressive, staying relatively stable over time, perhaps more like type 1.
And can it spread?
Interestingly, yes. In some cases, the localized seizure activity can start to spread to involve other nearby body parts, or it might even evolve into a more generalized seizure that affects the whole body.
Wow, so that variability really drives home the point that EPC is often a symptom, right? A sign of something else going on.
Absolutely. It underscores that EPC itself isn't the disease, but rather a manifestation of some underlying issue in the brain.
Which leads us perfectly into the causes. Okay, so we have a clear picture of what EPC looks like. Now let's look under the hood. What do our sources tell us about the underlying causes?
Right, and this is where it gets particularly interesting and maybe a bit daunting, because the sources emphasize that the list of potential causes for EPC is remarkably broad.
Not just one or two things, then.
Oh, definitely not. In many ways, it mirrors the huge list of things that can cause other types of epilepsy.
Okay.
We're talking structural abnormalities in the brain, things like lesions or developmental issues.
Yeah.
Infections are on the list, metabolic problems, genetic disorders.
Autoimmune issues, too, you mentioned.
Yes, autoimmune processes where the body's own immune system mistakenly attacks brain tissue. Even certain medications or tumors, neoplastic processes.
So it's really a symptom pointing to potentially many different underlying problems.
Exactly. It's not a disease in itself, but a clinical sign of a wide range of neurological issues.
That must make diagnosis incredibly challenging. Can we dig into some specific examples that the sources often highlight?
Absolutely.
Yeah.
Let's start with structural causes. The sources frequently mention brain tumors.
Like gliomas.
Gliomas, meningiomas, both cancerous and non-cancerous types. Stroke is another big one.
Ischemic or hemorrhagic.
Both. Whether it's due to a blocked blood vessel, ischemic, or bleeding in the brain, hemorrhagic. Either can trigger EPC if it affects the right area. Traumatic brain injury is another potential cause, and also something called focal cortical dysplasia.
What's that exactly?
It's basically an abnormality in how a specific part of the brain's outer layer, the cortex, developed before birth, sometimes seen in conditions like tuberous sclerosis complex.
Right. And are these structural causes common?
Actually, yes. Some of the studies we reviewed indicated that structural abnormalities were the most frequently identified underlying cause in their EPC patient groups.
Interesting. What about infections? You mentioned those two.
Yes, infections are definitely documented as a cause, although maybe less frequent overall compared to structural issues based on some sources.
What kind of infections?
The sources list things like meningitis, including tuberculous meningitis, which is a specific bacterial form,
Okay.
and various types of encephalitis, which is inflammation of the brain itself, like herpes simplex encephalitis or other viral causes.
Anything else?
HIV is mentioned, and also neurocysticercosis, which is a parasitic infection in the brain.
Got it. And the autoimmune side seems really key, especially thinking back to Rasmussen encephalitis. It's like the body attacking itself.
Precisely. Autoimmune and inflammatory conditions are critical in a subset of EPC cases. Anti-NMDA receptor encephalitis is one example.
Right, I've heard of that. The immune system targets specific brain receptors.
Exactly. And of course, Rasmussen's encephalitis itself is a prime example of an autoimmune condition strongly linked to type 2 EPC.
Are there others?
Yes, multiple sclerosis can sometimes present with EPC. And the presence of certain specific antibodies like anti-MIGO or NO1-NDQ are also implicated.
It's like specific markers for immune attack?
Kind of, yeah. They point towards an immune-mediated process. The sources even mention LGI1 antibodies.
And were those linked to something else?
They are more commonly linked to limbic encephalitis and a very specific seizure type called faciobrachial dystonic seizures. But they have been seen with EPC too.
So the immune system is basically misfiring, mistaking healthy brain cells for threats.
That's a good way to put it. The body's defense force gets confused and launches an attack, leading to inflammation and neurological symptoms like EPC.
Quite a range of autoimmune links. What about metabolic disorders? That seems like a totally different category of problem.
It is, and it's another important one. Metabolic disorders represent a whole other avenue. Our sources detail quite a variety.
The jazz.
Things like disorders affecting how the body processes amino acids, organic acids, or neurotransmitters,
Right.
the brain's chemical messengers.
Okay.
Mitochondrial diseases are also implicated. You might have heard of MELIS, Lee syndrome, MER.
Vaguely, yes. Problems with energy production in cells.
Essentially, yes.
Oh.
And conditions linked to the PLG, which is involved in mitochondrial function,
Hmm.
those can sometimes manifest as EPC.
Any others?
Also, inborn errors of metabolism genetic conditions present from birth, like maple syrup, urine disease, or propionic acidemia, urea cycle disorders too. And even non-ketotic hyperglycemia, basically, very high blood sugar without ketones.
Wow. So metabolic issues aren't insignificant.
Not at all. The sources suggest they can actually account for a notable percentage of EPC cases, perhaps more than initially thought.
And finally, genetics. Seems like genetics are popping up everywhere in medicine now.
They really are. Our understanding of the genetic basis of epilepsy in general is just exploding, and EPC is part of that picture.
Are there specific genes linked to EPC?
Yes, mutations in certain genes have been identified, for example, the KCNA2 gene. Mutations there often present specifically as continuous focal motor seizures, a lot like EPC.
Interesting.
And then there's the SCN1A gene. That one's more typically associated with really severe epilepsies like Dravet syndrome.
Right.
But sometimes mutations there can manifest as prolonged fever-provoked EPC. So the presentation can vary even with the same gene.
So genetic causes are definitely an area to watch.
Absolutely. It's an area of growing recognition in the context of EPC. Just to give a little more context, those genes, KCNA2 and SCN1A, they're involved in controlling the electrical gates, the ion channels, in brain cells.
So mutations mess up the electrical signaling.
Exactly. They can disrupt the normal electrical activity and potentially lead to seizures like EPC.
It is almost overwhelming, the sheer number of potential causes. And the sources also mention that sometimes you just don't find the cause.
That is the frustrating reality in some cases, unfortunately.
Mhm.
Despite a really thorough investigation, the underlying trigger remains unknown or cryptogenic.
Right. Given this incredibly wide range of potential underlying causes we've just gone through, it seems obvious that figuring out what's actually driving the EPC in any one person must be a complex process.
It certainly is.
So let's delve into how doctors actually approach diagnosing this condition. What's the process?
You're absolutely right. It is a complex puzzle. And the sources really emphasize that a comprehensive neurological evaluation is the essential starting point.
Makes sense, given all the possibilities.
Exactly. You need to consider the vast array of potential underlying conditions and any associated illnesses the person might have.
And EEG, the brainwave test, that must be a primary tool, trying to listen in on the brain's electrical activity.
It definitely is. Typically, an EEG and EPC will show focal epileptiform activity, meaning abnormal electrical patterns like spikes or sharp waves or maybe just slow wave activity. That seems to be coming from the specific area of the brain thought to be generating the seizures.
Okay.
Sometimes they might see something called PLEDs, periodic lateralized epileptiform discharges. Think of it like a repeating, localized electrical storm showing up on the EEG map.
So the EEG usually shows something.
Usually, but not always. And this is important. The sources highlight that the EEG can sometimes be surprisingly unrevealing.
Like, really, it can look normal.
Yes, it can appear normal in up to maybe 20% of patients with EPC.
Why would that be?
Well, it could be that the seizure activity is originating from a really tiny patch of the cortex, too small to be easily picked up by the scalp electrodes.
Oh.
Or it might be coming from deeper subcortical regions of the brain, which are also harder for scalp EEG to detect clearly.
What about in Rasmussen's? Does the EEG look different there?
Yes. In Rasmussen encephalitis, the EEG often shows quite significant slow-wave activity, usually predominantly over one side of the brain, reflecting that more widespread inflammation and dysfunction.
Which contrasts with the more localized changes in type 1 EPC.
Exactly. The more contained EEG changes in type 1 often point towards that more limited focal structural cause.
What about imaging? MRI seems like it would be absolutely crucial for spotting those structural abnormalities.
Indispensable, really. Magnetic resonance imaging, MRI, is considered a cornerstone of the diagnostic workup for EPC.
Why is it so valuable?
Because it's excellent at visualizing the brain structure. It can help identify potential underlying causes like tumors, evidence of a past stroke, scarring, or those areas of cortical dysplasia we mentioned earlier.
So it helps pin down the why.
Precisely. Clarifying the underlying etiology is a major role for MRI here.
Are there any other diagnostic tools that experts might use, other imaging techniques?
Yes, the sources do briefly mention some other advanced neuroimaging techniques, things like PET scans, positron emission tomography, and SPECT, single photon emission computed tomography, and also MEG, magnetoencephalography.
What can those show?
These techniques look more at brain function or metabolism. Sometimes they can reveal an area of the cortex that's hypermetabolic or hyperactive.
Meaning it's working overtime.
Kind of, yeah. Showing increased activity that corresponds to where the EPC is originating. It can provide further clues about the seizure focus, especially if the MRI is normal or unclear.
Okay, so let's say we've managed to arrive at a diagnosis of EPC, and hopefully we've even identified the underlying cause. What happens next? What do treatment strategies look like?
Right.
And what kind of outcomes can people generally expect?
So the sources consistently emphasize that treatment really centers on a dual approach.
Two main goals.
Exactly. First, you need to try and control the ongoing seizures themselves, usually with anti-epileptic medications.
Okay.
And second, and this is crucial, you need to identify and, if possible, treat the underlying cause of the EPC. Addressing the root problem is key.
Let's talk about the medications first. What are some of the commonly used ones to stop the actual seizures?
Well, benzodiazepines, drugs like lorazepam or diazepam, are frequently used as a first-line initial treatment. They're given to try and quickly interrupt the acute seizure activity.
Do they work well?
They often work initially, yes, but the sources note that, unfortunately, the seizures frequently tend to recur once the immediate effect of the benzodiazepine wears off.
So they're often not a long-term solution on their own.
Generally not, no. So other anti-seizure medications are usually needed. The list includes drugs like fosphenytoin, clobazam, valproate, levetiracetam.
Levetiracetam, that's Keppra.
Yes, that's the common brand name.
Yep.
Also, lacosamide, topiramate, and carbamazepine are used.
Any standouts?
Interestingly, there's some evidence mentioned in the sources suggesting that using levetiracetam earlier in the treatment course might be particularly beneficial in some EPC cases.
Finding the right medication or combination sounds like it can be tough. The term pharmacoresistance came up before, especially with type 2 EPC.
Yes, pharmacoresistance, meaning the seizures just don't respond adequately to the medications, is a significant hurdle. It's particularly challenging in type 2 EPC, associated with Rasmussen encephalitis.
Right.
And it's not just about effectiveness. The source is also cautioned about potential complications from the anti-seizure medications themselves.
Like side effects.
Yes, things like aspiration pneumonia or encephalopathy, where the medication itself affects brain function negatively, or even respiratory failure, especially if high doses of benzodiazepines are used perhaps too aggressively. It's a balancing act.
Definitely sounds like it.
Yeah.
Now, beyond those standard anti-seizure drugs, the sources also mention immunotherapy. Is that an option when medications aren't working well?
It can be, yes, especially in those resistant cases, and particularly when an autoimmune process is suspected or confirmed as the underlying cause.
Like in Rasmussen's again?
Exactly. Immunotherapy aims to modulate or suppress that misdirected immune attack.
What kinds of immunotherapy are used?
Treatments like tacrolimus, intravenous immunoglobulins, VIGE, natalizumab, rituximab have been explored. Even antivirals like ganciclovir or things like intraventricular interferon alpha.
Wow, quite a range.
Yes, and anakinra, another specific immune-modulating drug, has also been used specifically in Rasmussen's encephalitis, according to our sources.
So if medications and maybe immunotherapy aren't enough, is surgery ever considered?
Yes, epilepsy surgery can indeed be an effective option, but it's for carefully selected patients.
What makes someone a candidate?
Generally, it's for cases where the seizure-focused patrovart, the specific area where the EPC is starting, can be clearly identified and is located at a part of the brain that can be safely operated on.
What kind of surgery?
Procedures like cortical excision, where the problematic brain tissue is actually removed,
Okay.
or something called multiple subsupial transections. That involves making small cuts in the cortex to disrupt the spread of seizure activity while hopefully preserving important neurological functions nearby.
Right. Now, what about the duration? We touched on this, but how long does EPC typically last? Is it always long-term?
There's a very wide range mentioned in our sources. It can last for just hours in some people.
A relatively short episode.
Relatively, yes. But for others, it can persist for years and sometimes even decades. It's incredibly variable.
And the prognosis, the long-term outlook, that seems to be really tied to the underlying cause, doesn't it?
Absolutely, that's a major theme. The prognosis largely depends on why the EPC is happening.
So stable causes might mean a better outlook.
Generally, yes. If the underlying cause is something stable, like a fixed lesion, maybe an old stroke scar, or a non-progressive vascular malformation, the prognosis might be more favorable compared to a progressive disease, like an aggressive brain tumor, or ongoing inflammation like in Rasmussen's.
And we already established type 1 generally does better than type 2.
Correct. Type 1 EPC nearly has a more positive outlook than type 2 or Rasmussen encephalitis.
Are there other factors that influence the prognosis?
Yes, the sources mentioned a few. Things like the specific pattern seen on the EEG can sometimes offer clues. The intensity of the treatment required might reflect the severity. And also, when the EPC develops during the course of an underlying illness, early versus late can sometimes matter.
Okay.
And notably, one study pointed out that a longer delay before starting effective treatment was associated with a longer duration of the EPC episode itself. Prompt treatment seems important.
That makes sense.
Yeah.
Unfortunately, though, the sources also mention potential long-term neurological consequences. It's not just the seizure itself.
No, sadly not. Depending on the cause and the severity and duration of the EPC, potential consequences can include cognitive decline, problems with thinking, memory, learning, persistent motor deficits, ongoing weakness, or coordination problems in the affected body part.
Right.
And in some of the more severe cases, or with particularly difficult underlying causes, EPC can unfortunately be associated with fatal outcomes.
That mortality rate you mentioned earlier from the systematic review.
Yes. That finding of around 11.8% mortality in the reviewed cases really underscores the seriousness of EPC. Even though it doesn't always have that dramatic loss of consciousness we associate with generalized seizures, it's a significant neurological event with potentially severe consequences.
It's quite sobering to consider the potential impact. Now, the sources we've looked at also include some specific findings from research studies. Can we touch on some key takeaways from those investigations?
Definitely. One of the systematic reviews we examined really reinforced that point about duration. It highlighted that EPC typically persists for at least several hours, often stretching into days or even longer, despite various treatment attempts.
So it's often quite stubborn.
Very often, yes.
Ah.
And as we just discussed, that review found the mortality rate in the cases they looked at was around 11.8%.
Okay.
It also confirmed that while benzodiazepines are very commonly used right at the start.
The first-line approach.
Right. But seizure recurrence after their initial effect wears off is quite typical. The review really stressed the need for a judicious, careful approach with antiseizure medications, balancing the need for seizure control with the real risk of potential harm, like respiratory depression from excessive doses.
Finding that right balance seems critical. What about the study focusing on timing? Did delays matter?
They did seem to. That study found a correlation, a link between delays and different phases of EPC management, like diagnosis, starting treatment, and a longer overall duration of the EPC episode.
So faster intervention might shorten the episode.
That's the implication. Interestingly, they also found a link between higher blood glucose levels when the EPC started and a longer time for it to resolve.
High blood sugar. Why would that matter?
Well, the researchers suggested that maybe high blood sugar could act as a kind of trigger or exacerbating factor, particularly in patients who already have some underlying brain injury or susceptibility.
That's fascinating. What about the study comparing the clinical picture, the outcomes, and the EEG findings?
That study looked at a group of EPC patients and found that brain tumors and ischemic stroke were common underlying causes in their cohort, aligning with the structural causes being frequent.
Okay.
It also reinforced that distinction between type 1 and type 2 EPC we discussed earlier.
So?
They found type 1 EPC was associated with older age when it started, generally fewer cognitive problems, a better response to the anti-seizure medications, and a higher chance of the EPC eventually stopping or going into remission.
Which fits with the generally better prognosis for type 1.
Exactly.
And there was one final point from the research about the location of the twitching.
Yes, a really interesting observation. The sources noted that the specific topography of the EPC, meaning the precise body part that's affected by the continuous muscle activity, often corresponds very closely to the representation of that exact body part on the brain's motor cortex map.
So if your thumb is twitching, it's likely the thumb area of your motor cortex that's firing.
Precisely. It's like you're seeing a direct, albeit abnormal, map of brain function playing out on the body, a compelling link between brain location and bodily function.
That really illustrates the focal nature of it. Okay, so to try and synthesize everything we've explored in this deep dive, what's the most crucial insight we should take away about Epilepsia Partialis Continua?
I think the most important thing to understand, really, is that EPC is this rare, quite intricate neurological condition. It has this remarkably diverse range of potential underlying causes, different ways it can present clinically, and subsequently, quite varied outcomes.
It's not simple.
Not at all.
Mm,
And while the persistent nature of the seizures, especially with that preserved awareness, can be incredibly unsettling for the patient and their families,
understandably so.
identifying that root cause, the why behind the EPC, is absolutely paramount. It's the key to guiding the most effective treatment strategies and for giving some idea about the likely prognosis, the path ahead.
And it sounds like the story isn't finished. Research is ongoing.
Oh, absolutely. Research continues to deepen our understanding of the mechanisms behind EPC, refine diagnostic approaches, and develop better, more targeted treatment strategies. The medical community is constantly learning more.
That's encouraging. So for you, the listener, perhaps consider this final thought as we wrap up. Given this sheer array of potential triggers, we've discussed everything from structural brain changes to metabolic imbalances to autoimmune attacks, and given how prolonged EPC can be in many cases.
Lasting days, weeks, or longer.
Exactly. What might be the very long-term effects of that sustained, localized neurological overactivity on the brain itself? Effects that go beyond the immediate symptoms or the known consequences, like motor deficits or cognitive issues we've talked about.
Are there more subtle, lasting changes happening?
Right. What does that continuous storm in one part of the brain do over the long haul? It's certainly a question that warrants more investigation and research.
A fascinating area for future study.
Thank you for joining us for this deep dive.